Welcome to RUMC Connections. Welcome to RUMC Connections. My name is Meredith Gaskins, and I'm joined today by Podiatrist Dr. Michael Piccarelli. Welcome.
Thanks for having me.
Through RUMC Connections, you'll meet the fantastic doctors, nurses, and medical professionals that make our hospital thrive. We'll also provide useful information about your own health, explore the latest medical news, and hopefully get you answers to some of your own health-related questions. So we're talking feet today. The feet are complex mechanical structures of the human body, each consisting of 26 bones, 33 joints, and over 100 muscles, ligaments, and tendons. They serve as the foundation for the entire body, offering support, balance, as well as impacting overall well-being. Ongoing conditions stemming from the feet can lead to patients experiencing pain in their knees, hips, and lower back. Richmond University Medical Center's Podiatry department offers a robust lineup of ambulatory and inpatient podiatry services. RUMC's podiatry experts specialize in diagnosing and treating a wide assortment of foot and ankle conditions. On today's episode, Dr. Piccarelli will discuss bunions and the new approaches for treatment. So just to give you a little bit of background, Dr. Michael Piccarelli is a trusted podiatrist offering special care for feet of all ages. He is board certified in foot surgery and reconstructive rear foot and ankle surgery. He completed his undergraduate education at Wagner College with a Bachelor in Science in Biology. He then went on to continue his education at New York College of Podiatric Medicine, where he was valedictorian of his class. He was inducted into the Pi Mu Delta National Podiatric Service Honor Society. Dr. Piccarelli completed his residency training at St. Vincent's Catholic Medical Center, where he served as chief resident his final year. Currently, he is the podiatric residency director at Richmond University Medical Center, training the future of podiatry. Dr. Piccarelli continues to strive for excellence with continuous postgraduate training in diabetic limb salvage and reconstructive foot and ankle surgery. Dr. Piccarelli has completed advanced training in trauma, external fixation, and foot and ankle arthroscopy through the American College of Foot and Ankle Surgery. So, welcome once again.
Thank you.
And please, let's talk bunions.
Sure.
So, what are bunions exactly, and how do people get them?
Bunions in the general population is just considered as the bump at the big toe joint. It's actually a pretty complex deformity that's kind of malalignment of the big toe joint in 3 different planes.
Okay.
And leads to pain and shoe gear discomfort and things of that nature.
Mm-hmm. So now this is only occurring on the big toe?
The classic bunion occurs at the big toe.
Okay.
Yes. There's a bunionette, which is on the 5th toe. Oh. It's got its own cute little name.
Okay.
And bunionette. Not quite as complex of a deformity, yes.
Okay, perfect. So why are bunions a problem for so many people?
Generally speaking, the malalignment leads to abnormal joint stress, which then leads to pain, and secondary, the malalignment. And then sometimes it's just a shoe fit issue. You just can't fit into shoes comfortably because of the bump or the enlargement at the joint. Okay,
so are shoes to blame for bunions?
They are definitely part of the blame. Mm-hmm. It's part genetic, meaning your foot structure, kind of your inherent genetics, and then activity demands or shoe fit. Shoe fit is obviously more problematic for women, particularly, you get some younger patients come in and they show me the shoe they want to wear and the foot is already wider than the shoe.
Oh, yeah.
So we have to start working from that point. Okay. It's a nuisance type of a problem for a lot of people.
Okay. So now some people you said can be genetically predisposed to bunions.
Yes.
What does that foot type look like?
So there are other deformities such as metaductus and things like that will predispose you to that. It's pretty rare to have it as a juvenile, but it is there. It is a thing. And what I mean by the general foot structure is how your joints and whatnot are aligned relative to normal. And that will predispose you to potentially getting a bunion or not getting a bunion.
Okay. And what is the average age for patients that you do see with bunions?
Probably, middle-aged women is the most common. I've done them as young as, the early 20s.
Okay.
But the most common age is probably right around middle age for women.
Middle age. Do you think that stems from years of like wearing heels?
It is definitely a contributing factor. No
Okay.
question about it. No question about it.
Okay. When it comes to pain from bunions themselves,
Yes.
is it important to differentiate whether it's pain in shoes or pain with bare feet?
If it's simply just shoe rub or
Yeah.
shoe pressure, a lot of times that can just be accommodated for.
Okay.
If there's pain in the joint, pain with activity, sometimes there is pain at rest. That's obviously kind of the next stage or a little more advanced. There's probably some early arthritic changes or inflammatory changes going on in the joint. So that kind of brings you to the next step. And that will be, treated either with anti-inflammatory, sometimes injections, shoe modifications. And then if all of that fails, then you're looking at surgical intervention.
Okay. And what we said, the type of shoes like high heels do play a part in developing the bunions, being that it's obviously mostly women who wear the heels. Do you see bunions in men
Sure.
as well? You do?
Sure. To differentiate, again, it's kind of some subtypes. The malalignment, or kind of what the general public will think of as the bunion, is definitely more the middle-aged women. And then there's more arthritic type of bunions where the bunion is more, say, on the top of the joint.
Okay.
That's more of a general arthritic condition that's more common in men. Women do get it also. So it's a little bit of a different treatment paradigm. However, it tends to be a little bit more advanced. The arthritic change is a little more advanced type of problem, so the different procedures and whatnot to handle that.
Okay, so walk me through it. Somebody comes into RUMC for a bunion. What are the first steps? What can they expect?
Assuming, middle-aged woman comes in, she's been complaining of, shoe fit problems. And if she's failed, prior non-operative interventions like we spoke about before, we give her the options for surgical management. Traditionally, it was done under an open approach, meaning an incision, frank incision, open. There's a cutting of the bone and realignment. It's not a shaving of a bump in any real way anymore. And what's called an osteotomy is done, and that corrects the alignment, and then soft tissue balancing. The newer approach is no incision technique. It's called MIS, or minimally invasive type of surgery, where through portals, similar to either arthroscopic or laparoscopic surgery, under x-ray guidance, we're making the bone cuts, realigning the joint, and then putting the fixation in. And it's worked at the first metatarsal, which is the bump that most people will see, and then in the hallux or the big toe itself. So 2 different procedures are done to realign, and it's done through 5 portals versus a long incision.
Wow. And I would imagine because it's minimally invasive that the recovery time is shorter?
Exactly.
Okay.
So less pain, less swelling, less scarring. You're able to ambulate same day. Stand and walk same day as long as you can tolerate it. It's also seems to be now. It's still a relatively new procedure. Within the last several years, but all the studies are showing lower recurrence risk because of how it's treating the true 3-plane deformity, not just the bump that you see. You're actually rotating the joint when you do the osteotomy back into alignment, so you're not relying on just soft tissue balancing. It's all osseous realignment at this point.
Okay, so that's great. So you're seeing less reoccurrence with this
Correct.
new method. How about with the former method? What was the likelihood of a bunion coming back?
Depending on kind of where you started from.
Okay.
So what we measure, or we would traditionally measure, would be angles. Obviously, the larger the angle, there would be different procedures to decrease the recurrence risk. But overall, there was probably about 10 to 20% recurrence risk in the global aspect of prior bunion surgery. They don't have any concrete studies now quoting we're at 3% or 5%.
Yeah.
But all the anecdotal evidence is showing definitively less recurrence.
Okay. What various treatments are available before surgery? You mentioned injections.
Yes. Standard cortisone injection, steroid injection that's decreased, pain and inflammation. There's paddings and, again, shoe modifications. Orthotics do play a role. What we try to get across to patients, the orthotics don't necessarily change or treat the progression of the deformity. What they do is kind of manage the symptoms that the patients are currently having. Best kind of comparisons like eyeglasses. They don't fix your eyesight. They just allow you maybe to see better, read and things of that nature. Whereas the orthotic is not going to fix the problem, but just may allow you to function a little bit better, maybe delay a procedure.
What percentage of patients would you say can get away with just those treatment methods?
I would say probably about a quarter of the patients that are in a stage where they can be considered a surgical candidate. Now, obviously, if they haven't tried any of that, then they would go down that path first. But the people who would come in based on the actual x-ray findings and deformity Probably about 25% of the time they can manage or delay symptom or delay procedures using orthotic.
Okay. So with this new surgery, you said they walk out the same day on their own.
They can walk out
Are
same
they
day.
in a boot or?
Traditionally, they will be in a surgical shoe, which is
Okay.
the flat wooden
yeah.
shoe
I
that
had
I'm
one
sure
of
you've
those.
seen them. Yes, people walking around.
Yeah.
And I will take x-rays generally around the 2-week mark. If everything looks good and the portals are healed well, they can begin transitioning to wider shoes and sneakers and things of that nature. So it's really cutting down the actual downtime. Now, I don't want to minimize it in the sense bone is bone, still going
Yeah.
to take about 6 weeks, 8 weeks to
heal,
heal.
of course.
So there'll be limited activity for that time, but your day-to-day life is much less disrupted nowadays than it's been in
I'm
the past.
sure. Because the previous, would you need to stay off for a number
Depending
of
on the
weeks,
procedure,
or-
there would be procedures where you'd be on crutches for 6 weeks.
Yeah.
Sometimes early weight bearing, but then your return to normal activity was definitely delayed. You're waiting on incision healing, much more swelling than we currently have been experiencing with the MIS approach.
And how about if somebody has bunions on both feet? Would you do both feet at the same time, or?
I try to talk them out of it.
Yeah.
It's not an impossible thing to do, but you really want to have a good leg to stand
Of
on
course,
for a
of
period of
course,
time.
yeah.
Generally speaking, it's younger patients, women or even men, you kind of 20s, 30s that will do that, where we can kind of overlap the recovery in a sense, where do a bunion, several weeks later come back and do the other one, and now their global recovery is a little bit shorter versus say waiting 3-4 months between each foot.
Okay.
Which is, and again, an advantage of the newer techniques.
Absolutely. Are there any type of like foot rehab exercises that you have patients do?
Yes, actually. Generally, particularly women, they're looking for heel height, okay? And we will have them perform range of motion really as soon as they can tolerate it, first couple of days post-op. And again, one of the advantages of this is you're not so worried about getting into the shoe because you're not as swollen as you were in the past. So you can return to shoes
Can return to heels.
earlier, yes. And because of less scarring and less soft tissue dissection, any stiffnesses in the joint is much less. So returning to a heel height, of any significant degree is much, much easier. Whereas in the past, you'd have to sometimes go through a formal physical therapy course. That's pretty rare nowadays.
Okay. That's good to know. And what are some common complications that occur from bunion correction surgery?
Really, the most common complication is pretty much like any other surgery. Local infection or something like that is generally treated with an antibiotic, but that's, again, much less so now. Sometimes the hardware would have to be removed. Some people just don't want screws left in. I try to
Okay.
talk them out of taking them out.
Yeah.
Why have another procedure if you don't have to?
Okay.
Like a knee implant or a hip replacement, they can just live with you. There's no downside to them. But the complications have really diminished. And the big complication in the prior surgeries was recurrence.
Yeah.
5 years, 10 years down the road. And that seems to be cutting down now.
Because a lot of patients obviously can be intimidated with surgery, these newer surgical
Sure.
options, I'm imagining, would have less pain for the patient if they could walk
Yes.
out the door
Yes.
after surgery. So what does medication look like? Is it just standard?
We still give some pain medication for the first few days. One of the other things we use up at the hospital is something called Exparil. It's a long-acting block.
Okay.
Whereas post-operatively, we give it, and you can get 24, 48 hours of relief or numbness of the surgical site before needing to take any pain medicine. That seems to cut down on
Yeah.
any narcotic use. But they will get pain medicine for a couple of days. I will say it's almost unheard of to refill any pain medication after a bunion surgery. So after 3-4 days, I generally will do elective surgery on a Wednesday, and we see them back on the Monday. They're not on anything,
Wow,
maybe a
that's
Tylenol or something.
And then in a matter of weeks, they're, back in action. And
Generally, I would say on average, they're in a shoe by about the 3rd or 4th week. Like I said, I can clear them as soon as the 2nd, but then some patient apprehension, usually
Yeah.
just kind of resuming and making sure everything's okay. So usually about the 3rd or 4th week, they're in sneakers.
I mean, this sounds like a tremendous advancement.
Yes.
In surgery.
Seeing kind of from where I was as a resident
Yeah.
through early kind of career to where we've come, it's probably one of the bigger advancements actually in foot and ankle surgery.
Okay.
Is kind of the newer technique for bunions.
Yeah.
Absolutely.
And what do you think will be the future? Are there any other advancements on the horizon?
Everything is trending towards smaller and smaller incisions.
Yeah.
So either done arthroscopically or a combination with minimally invasive approach and X-ray guidance. That seems to be the trend, and for the benefit of the patients.
Yeah. And any robotic procedures, you think?
I haven't done any, but I
Yeah.
would love to figure out a way to try it, to be honest with you, as I see them, using the Da Vinci up at the hospital.
Yeah.
We haven't crossed that bridge yet.
Not yet. Okay. Possibly in the future.
Possibly in the future, yes.
Okay. Are there any other items that you'd like to share with us about bunion correction?
Sure. So one of the other advancements in it, getting to the other type of bunion, meaning the arthritic or the hallux rigidus,
Yes.
as it's termed, is arthroscopic approach.
Okay.
So for more minor arthritic changes where we're doing something, what's called a chylectomy, or kind of cleaning up the joint, for lack of a better term, there is a trend now to start going arthroscopically, which instead of, again, an open incision, it's 2 portals centered right over the top of the joint, less pain, less scarring, and you can do most of what you needed to do through that approach. Now, in more advanced cases, that's not possible yet.
Okay.
But for the more mild to moderate cases, it is. We actually just did one last week up at the hospital.
Really?
Yeah.
And how'd that go?
Went great. Went great. It's pretty satisfying when you can kind of accomplish something through 2 pinholes versus
course.
an open incision. And when you see the patient for the follow-up and they're like, well, that's it. I'm like, that's it.
Yeah.
That's it.
Now, you've been in practice for a long time. Do you have a most memorable case that really stands out to you?
Oh, I don't know how much time we have for the most
know.
memorables, because there's memorables in many different ways.
Yeah.
Yeah, I will say, actually, a recent patient that I was speaking with just a couple of days ago in the office, where we did more advanced procedure for a diabetic type of procedure. And she calls me a couple of days later that she's in Albany and she's having some pain. I'm like, why are you in Albany? How did you get out of your house? You're not supposed to be walking. So you get some of those. There's always interesting.
Yeah.
And then the rewarding ones are, where you've either restored function or salvaged a limb. And it's so nice to see kind of the patients when they're grateful for that.
Yeah.
That never gets old.
No, that
to
has
be
to be
honest
the
with
most
you.
rewarding part, I'm sure.
Yeah, it never gets old. I couldn't walk and now I can, or I was in pain and I'm not, or they told me they wanted and we were able to salvage it. Those are really the best.
Wow.
But there's the funny ones in there too.
Yeah.
They are
Do you have a good
definitely
funny one?
That was the one in Albany, and she's laughing as she's telling me, she's
She
going,
knows she's not supposed to.
you sounded confused. I'm like, well, yeah, I was. How you got there? It was just a bus trip. I'm like, oh my goodness.
Yeah.
Oh my goodness.
That's so funny. So now everything is, full capability, surgical procedures, everything can be done within RUMC. People don't have to cross the bridge, go to the city. They can do everything right at home.
We are a full service facility. Yes, absolutely.
Okay. Now, why podiatry? How did you decide?
It's kind of just like anything else. I just kind of fell into it. I didn't have any specific goals, like that, of that saying being in college. I knew I wanted to do something in medicine. I looked at, a bunch of different fields, and as doing the research, this kind of allowed me to kind of do what I wanted to do, kind of specialize in a way, pretty much right away. And it kind of just went down that path.
Yeah.
It wasn't kind of pre-thought out. It just, as I progressed through college and then the application process, this is where I am. I wouldn't be, changing for a world.
Of course. And what do you like to do to decompress after a crazy
Okay, so decompression is generally I will work out to some degree, 3-4 days a week. Spend time with my family, my kids, who my older daughter is going to college soon.
Nice.
So that's an adjustment.
Yeah.
Just hang out at the house. Really anything that's relaxing, I'm down for at that point. And, watch some sports and regular type of stuff.
Nice. Okay, very cool. Well, thank you for all that you do to keep our community
pleasure.
safe and well. For more information about the podiatry services at RUMC, you can call 718-818-4570 or visit rumcsi.org. That about does it for this episode of RUMC Connections. I'm Meredith Gaskins.